Welcome to. Hello everyone, I am Dr. Sandeep Vijayaraghavan. I am a plastic surgeon at Amrita Institute of Medical Sciences, Cochin. Today I want to talk to you about treatment of wounds. See, all of us, when we are in hospitals, when we start off our career or when we are in the emergency room, we get a lot of wounds coming to us. It might be very small wounds or very large wounds, and many of the times we are the people in the emergency room who would be actually tackling all these wounds. So I'm just going to talk to you basically about how to tackle the patient who is coming with the wounds. So basically, once we come, normally when we were actually starting off, we used to immediately look at the wounds. If there's a dressing, we used to remove the dressing and then we used to check out the wounds. But many a times what happens is that wound might be very painful, especially when we are removing it, even though we are putting saline or other solutions on it and then removing the wound dressings, it would still be very painful. So what can we do for that? Ideally, we should actually go and give a block somewhere proximal to it or give some local anesthesia before we actually remove the dressings itself. It might not be possible in all circumstances, but as far as possible, try to do that. So once you get better and better at giving blocks, once you know about how to give blocks, then you would be able to do that in a much better fashion. Say for example, if you are actually going to do something for the upper limb, say for example, if it's some fingertip injury, you could actually give a digital block. But if it's like a whole big laceration in the forearm, probably you'll have to give an axillary block. So giving an axillary block might not be very easy. You might require the help of an anesthetist. So we have to actually plan accordingly itself. You can ask your seniors in the emergency room what to do, or you can ask your anesthetist also what to do. But smaller things, definitely like small cuts, abrasions and all, either you can give local anesthesia or around that wound field block, or you can actually give small digital blocks or wrist blocks. All those things are very easy. We'll probably come to how to give anesthesia in a different video. But here we would actually emphasize that what we must understand is that we should calculate the dose of anesthesia. It should not be more than the dangerous level of giving anesthesia. And then what is the anesthetic material that we are going to give? Are we going to give just lignocaine, or we are going to give lignocaine with adrenaline, or are we going to give sensorcaine or ropivacaine? So those are the things that we would discuss in detail in another video. So once the anesthesia is given, we can actually remove the dressings without pain, and the patient itself will be very comfortable, and I am sure that the patient would tell that doctor is a great doctor because he didn't cause any pain when he removed the dressing, because he is going to remember all those things, because suturing other things anywhere is going to be pain free because local anesthesia is going to be given, right? So the first experience is the best experience. So the first itself, when you're examining, as far as possible, try to make it pain free, right? The next part, we want to see how you're actually going to prepare the skin. So we know that commonly we use actually povidone iodine for actually preparing the skin. So at certain times it might be a run over injury, it might be having some kind of grease etc. on the wound. So then what happens? So there would be oily substance in the wound. So then you will have to have something like Savlon, that is it's basically chlorhexidine and cetrimide. So the combination has got some sort of detergents also in it. So all the oily stuff, everything would be removed with that. Otherwise, we use povidone iodine, either a solution or a scrub. If it is a scrub, you can actually get a lot of foaming also, and you can actually remove a lot of dirt and grime etc. from that particular wound. So you decide whether you want to have cetrimide or whether you want to have povidone iodine, and then you can do accordingly. Then you have something like chlorhexidine plus you have alcohol, say probably 0.5 weight by volume of chlorhexidine, and you have around 70% alcohol solutions also. Those are not done for use for open wounds. They can only be used for closed wounds. Say for example, you suspect that there is some sort of a foreign body inside, or you have a fracture, you want to do something about it. Those kind of things only you use those solutions. Okay, so our important thing is in open wound, do not use high amount of alcohol content. It is not good for the wound. Again, the use of things like hydrogen peroxide, these are all controversial. As far as possible, try to avoid it, because you don't want the tissue that comes into contact with the hydrogen peroxide to die. So that is also a problem. So most of the time we would be able to clean the wounds with chlorhexidine and cetrimide solutions, or we can use the povidone iodine scrub or solutions. So before we start the suturing, we should know what are the instruments that are required for suturing. So as a plastic surgeon, our main instruments are basically 3 instruments. We have to have a good needle holder, we have to have a good forceps, we always use tooth forceps, and then we should have a scissor to actually cut the sutures. But before we do, almost all the wounds that we suture, we actually freshen the edges of the wounds. The reason why we do that is because any wound that has come, no, it is naturally, it is some trauma or something has happened and a wound has come, would not have a sharp edge unless it is a glass cut or knife cut wound. Even a glass cut and a knife cut wound also sometimes may have some bit of epidermis going inside the wound. So always a plastic surgeon would actually freshen the wound edges. So for that purpose, we would be having a scalpel also. So here I've got a scalpel. This is a scalpel, and we can actually put whatever blades, whether it's a 15 blade or a number 10 blade or 11 blade. In this case, I've actually put 11 blade, and then you can actually put it into the BP handle, right? So that is one thing. And then we have forceps. See, we use forceps which have got a tooth. Okay, this is a forceps which does not have tooth. This is a non-toothed forceps. This you can see is a non-toothed forceps. This is a toothed forceps, and the toothed forceps, in this particular case, you can see that there is a small platform also. The platform is actually to hold on to some suture needles, to hold on to needles. Okay, the platform is basically to hold on to needles. And then we have needle holders. So then most of the needle holders you would see would be either having a small roughed edge over here. So with that, the needles are held very tightly and the needles would not move. So a good needle holder is also very good. And also the needle holder should be well balanced one. You can actually see if you hold it like that, it will be well balanced needle holder. And the tip of the needle holder should be as thin as possible. So then what happens is that it is easier for you to actually take your bites, etc. Right? And then afterwards, the next instrument that you require is the scissors. So the scissors, for when you're actually using large sutures like say 2010 suture, you will be using a scissors like this. But at the same time, when you're actually suturing the face, where you're actually going to use say 50 or 60 sutures, you would probably use much smaller scissors. And then for removing the sutures, you have got a suture removal scissors. So this is the tooth forceps. This is a tooth forceps with a small platform you can see over here. That is basically to hold on to sutures. So it gives a much better strength. You can actually see that it just squeezes onto the sutures over here. And we have another forceps. These are non-tooth forceps. You can actually see that there are no tooth over here. But as a plastic surgeon, I would always prefer to use this particular forceps. You can see that I'm holding on to my tissue with this, but because it has got a nice tooth over here, I don't have to give so much pressure over there. I just have to gently hold on to it, right? So the problem is that this non-tooth forceps does not have that kind of a grip. See, it just slips off. So what happens? I tend to hold it more tight, and when I do that, you can see that the skin gets damaged. So that is why as plastic surgeons we always prefer to use this tooth forceps. You can actually see again. Okay, so that is the reason. This has got a good ratchet. So when we hold knee sutures, you're going to put in the ratchet over there. And because of this tungsten or other roughened edge over here, the needles would not move. So that is the use of the this is a needle holder. is a big and this is a small. Okay, and this is the thing for removing the sutures. You just take out the sutures like that. So this is the suture removal scissors, right? Okay, so I'll talk to you something about the sutures. See, basically before starting of sutures, we should know that there are different types of needles. So one of the types of needles is the original thing that we all used to do when we were actually medical students, is to go in for these eyed needles. You can actually see the needles have got a small eye through which we could pass suture material, and then that would be used as a suture. So it would be, the needles would be different types of needles would come with that. So nowadays these kind of needles are not very common. Then we have basically two different types of suture materials. We have non-absorbable sutures, and then we have got absorbable sutures. Okay, so that is something that we have to understand. So basically non-absorbable sutures could be something like silk, you could have polypropylene, you could have nylon. So these are the non-absorbable sutures. So in absorbable sutures we have polyglactin sutures, we have polydioxanone sutures, PDS sutures, or we could have glyconate sutures. These are basically, these two sutures are monofilament sutures, and then here you have got a braided suture. Again, in the non-absorbable sutures also, this particular silk is a braided suture, and rest of the sutures are mainly non-absorbable or monofilament sutures. So in the sutures itself we have different types of needles. So this is something that we have to understand. So there is a cutting needle. So we have different types of sutures. Basically we have, let us say, we have three different types of needles. One needle is a cutting needle. Then we have a reverse cutting needle. So you can actually see the symbol for that would be something like a triangle, right? So normally we prefer to use a reverse cutting needle for doing most of the skin sutures. Only for deeper tissue like muscle, etc., we would be using something like a round body, or better still would be a taper cut needle. So this would be the cutting needles, right? Then we have another needle which is called a taper cut. So that symbol would be something like this. You have a cutting part and then you have a circle around it. So this is a taper cut needle. And then we have again a round body needle. So a round body needle would have a symbol like this, a circle and a dot right in the middle of that. So these are the different types of needles. So we should know what needles to use where. So in general, all the cutting needles are used for doing sutures of the skin and the immediate subcutaneous tissue, because when we want to do good subcutaneous closure, we have to take the dermis. So for that, it is ideal that we take a cutting needle, right? And we can actually go for other needles in deeper tissues like muscle or any other suturing that you want to do. You can actually use the taper cut needles, right? So now we will come to the techniques. So we should know how to actually hold various instruments, right? So these are forceps. This is a tooth forceps. The tooth forceps is always held like you hold a pen. So it's basically, if you are using in this hand, you would be holding it like this, or if you are using it over here, you would be holding it like this. So you would see that it would be long enough to actually come and rest on your web space also. So this is how you hold a tooth forceps. Now we want to see how to actually hold a needle holder. So this is a needle holder. So I always tell my students that the most important part for our work is the needle holder, because ultimately all the things that you are going to repair requires suturing, and the suturing is the main instrument for suturing is the needle holder. So now we should know how we actually hold needle holders. So you can actually see that this is how I actually hold a needle holder. So my thumb would be going into this ring, one ring, and my ring finger would be going into the other ring. Okay, we see many people actually putting it like this. It is not correct. It has to be the ring. The ring finger and the thumb are the 2 fingers that have to go into these 2 rings. Next most important thing is you should have the thumb only this much inside. It should not be like that. That is not a good way. If you keep it like that, you will not be able to get a good, you will not be able to do the suturings well. So always it is held something like that. Okay, and then you have your middle finger and you have your index finger supporting the particular instrument. So what happens is that your needle holder should be an extension of your hand, and then after some time what happens is that you would not even be knowing how you are actually holding it, because it is like driving a car. Nobody actually tries to remember, okay, whether the gear is in the 3rd gear or the 4th gear or the 5th gear, right? It comes automatically. Similarly, this holding of a needle holder also comes automatically. It would be like this, and sometimes you would be actually holding it only partially like that, and then the important thing is that it would be moving around. It should be the extension of your forearm. Okay, so that is how you actually hold a needle holder. Now we will come to holding a suture with the needle holder. So this is a suture, this is a silk suture. Okay, I have opened because your sister is going to give you the suture like this, right? Right. Now coming to actually how to hold the needle with the needle holder. So you can actually see the needle would be like this, and then you have to hold the needle either in the middle or slightly towards the swage end of the needle. So let us say that I am going to hold it like this, and then once we do that, you put the rache and then you take out your suture. So that is ideally how you actually take out. So once you do that, see, this is how it is there. You see that this is perpendicular to it. So many people hold the needle perpendicular to the needle holder, or you could even have it slightly at an angle like that. You see, so this is probably a more comfortable way of doing it. It is your how you like to hold it. You could either hold it perpendicular or with a slight angle, but wherever you hold it, it has to be held at the tip of your needle holder. You can see it is right at the tip of the needle holder. You should not hold it like that. That is not a good way of doing it. It should be as close to the tip as possible, right? Okay, so this is how you hold a needle with a needle holder. Okay, the most important thing is when we are actually going to suture is how you are actually going to go into the skin. See, I am a right-handed person. Okay, this is how I am actually holding the needle. So the needle actually should pierce the skin at right angles. So that is the important thing. So you see how my hand is kept. So unless my hand is kept like that, I will not be able to go and do. That is why I always say that you should not have the fingers very much inside, and you should be able to move your hand like that. So it comes perpendicular. You see the needle comes perpendicularly inside, and then you see it comes to the other end also in a perpendicular fashion, and then you push the needle out. And the most important thing is, we know that this particular needle is a circular needle, so you have to take it out also like a circle. Okay, so that is how you actually take the needle out. So once that is done, you have to actually put a knot. So normally we do a surgeon's knot. So what you do is you take 1, 2, you take like that, and then you come, hold the other end, put the rache, and then you come across and you can actually lock it over there in place, and then you take the other in the opposite direction and close. So you are going to get a reef knot over there. Scissors. And cut. So this is basically how we actually put these stitches. I'll just show you once again. I've held on to the stitch. I come perpendicular to the wound, and then equal distance on the other side also I have to come, Okay, and I am actually coming out like that, and you see it comes as a circle, and then I pull it out and I hold close to the end, and then I take it like that and I tighten it, pull it to one side. This is called squaring the knot, so that it gets locked there. Nobody needs to hold it over there with another instrument, and then you do in the opposite direction. So one throw like this, one throw like that. So you have reef knots, one throw like this, one throw like that. Okay, and then you can actually cut your suture long enough for you to cut it later, right? So this is called a simple stitch. Now we will come to doing a mattress stitch. So in the mattress stitch, what happens? The mattress stitch, we actually go perpendicular to the skin over here, then come out at the equal same distance on the other side, see, and then you hold on to the center portion, put the ratchet so that it doesn't move, and then pull to whatever length you want. Okay, and you can actually change the direction either like this or with your hand. Ideally you have to do it this way, and then you see you go in close to the wound margin, and the other side same amount, same thickness on the other side. Okay, once you go there, you pull it out. Clockwise. Okay, lock it, that's done. So this is a vertical mattress. So now what is the difference between the vertical mattress and the simple suture? The problem with the simple suture is many a times the suture the end might actually go inward. It might actually go like this. And so what happens, we know that there's epidermis here, and if the wound is being stitched like this, epidermis to epidermis will not cause healing. Only the dermis to dermis only will cause the healing. So we want the end to be actually lifted up, everted like that. So in this particular suture, you can see the edges would be everted, and you would get beautiful approximation of these edges. So that is the advantage of doing this vertical mattress. Now let us see the next suture. It is called a horizontal mattress or a box stitch. So again we are taking the stitch and we go from the wound edge, you see, and then comes to the opposite side, and whichever place you want, you actually put the ratchet, pull it to the required length, come here, and then you can actually go in the opposite direction, and the same distance from the wound edge you go inside perpendicularly, and you see you come here like that, and then see the round fashion you have to take it out, and then you suture it. Take it that side, right? So this is called a box stitch or a horizontal mattress. Now we are going to come to the next stitch. It is called a far and near stitch. So let us say that there is no one to help me in the OR, okay, OR or in the emergency room, and I have to put the stitches, and it is having a lot of gap over there. So then how do I do it? I will show you by actually showing another cut that I have made. Turn it around. So in this particular stitch, so the problem is that when I'm trying to take the stitch, See, it might not come, it will be too tight, it might be difficult for me to close it, it will come off like that. So to prevent that, what we do is we go in for a far and near stitch. So in the far and near stitch, what we do is we come through one edge, come like that, come through the other edge, and then normally what happens when we are actually going for a horizontal mattress or a vertical mattress, we come back to the same position and go there. Instead of that, we are coming back to the first position, first side, and then taking the bite like that. The advantage of this particular stitch is that in case the wound edges are in tension also, we can actually close very easily. See, we can close very easily and comes very easily. Okay, so now what happens is that these are temporary sutures. So now we can actually close the other areas. Say for example, I want to divide it into halves. I go to the right of the center, I close that either with the horizontal mattress or a vertical mattress, but it is because it is very close, it comes very easily, so I do not have to worry too much about it. See, the tension is taken over by this particular stitch, and once I have actually done the suturing, say here again I put another one, because it's a bit worn out, there was a cut through, I'm sorry about that. Okay, okay, once this stitch is put, then we can actually cut this, because this is a temporary stitch, and then you can actually put rest of the sutures over here. So this is the advantage of the far and near stitch. Yeah, now we will see how to actually do suture removal. It's important as actually doing a suturing. So you can actually see in this particular case, you can actually see the knot is over here, right? So this knot is very close to this particular thing. So the basic funda is that when you are actually pulling it out, we don't want unsterile area. See, in this particular thing, this particular portion of the suture has been exposed to the outside climate. There could be all sorts of germs on this suture, especially if it is a braided suture. So if I'm cutting it over here and then pulling this thing, this part outside, what happens is the entire area of this unsterile stitch goes through the wound and then comes out. So it is not good. So we have to always do the cut on this end, which has to, see here, this is where we have to do the cut. Now the next important thing is, how am I going to pull it? Am I going to pull it like this, or am I going to pull it like that? See, if I am going to pull it like this, you will see it opens up. It's not good. Okay, that is not how you have to do. What we have to do is, you see, I'm cutting it here, I've cut it here, and you see I have to pull it towards this side, so that the tendency of this opening up is not there. So this is the skin stapler. So if you actually, this one, you can see that it would come out in this fashion. I don't know whether you can see that. Yeah, you can see that this is that fashion.
So the important thing is that you should actually have an assistant also, and both of you should hold the skin edges in a everted manner, and then you actually staple, and then don't take it off, go further up, again hold it like that. Okay, so now you are able to hold it better. So release it and then again do the same thing. So go forward, keep it up like that, release it, and then again go. So that is how you actually put skin staplers. So here also you can see that it is in the everted manner. It should not become inverted. So that is the most important thing.
Thank you.